The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast, where we navigate the maze of healthcare policy and economics each week. I'm your host, Marc Ryan, and thanks to everyone for listening in. Today, we're diving into the final 2027 Medicare Advantage and Part D rule released by the Centers for Medicare and Medicaid Services, and more importantly, what it actually means for plans, providers, and the market. Now, if this topic sounds familiar, it should. Back on December 12th, I did a podcast breaking down the draft version of this rule. At the time, I walked through the proposals and flagged what I thought were the biggest potential disruptors, especially around star ratings. Well, now we have the final rule. So today, I'm going to refresh you on the key proposals, talk to you about what actually made it into the final rule, and highlight what didn't. And most importantly, explain the real-world impact, especially financially. Because while this rule may not look dramatic on the surface, don't be fooled. The star rating changes alone are going to create major volatility and real revenue pressure across the Medicare Advantage landscape. And in some ways, the biggest story here is not what changed overnight, but what's going to play out over the next several years. We'll take our normal 3 breaks, so let's jump right into it with part 1, the star ratings overhaul. Let's start with the heart of the rule, star ratings. CMS made it clear that their goal is to refocus the STAR program on clinical outcomes, patient experience, and measures where there are meaningful differences across plans. At the same time, they want to reduce administrative burden by eliminating measures that don't really differentiate performance anymore. That sounds reasonable, but the execution is where things get a little interesting. So let's talk about the EHO for All reward and the fact that it is being eliminated. CMS finalized the elimination of the Excellent Health Outcomes for All, or EHO for All reward. But here's the twist. They kept the reward factor, and they effectively made the EHO for All removal retroactive to star year 2027, its first year. That's a big deal. Many plans, especially those focused on health equity and underserved populations, had already invested heavily in capabilities to perform well under EHO for All. And yet, CMS moved forward anyway. What's even more interesting is the lack of industry pushback on this retroactive adjustment. Large plans didn't strongly oppose it. Trade groups were relatively quiet, so CMS had a clear path to finalize it. The biggest losers here? Plans with high dual eligible penetration, special needs plans, especially those not benefiting from the reward factor. Number 2, let's talk about massive measure eliminations. CMS also finalized nearly all proposed measure retirements, with one exception. The diabetic eye exam measure stays put. Everything else, gone. We're talking about 13 measures being phased out, which include 2 call center performance ones, 2 for appeals, 2 for complaints, 2 for disenrollment, the CAHPS customer service question, the CAHPS healthcare quality question, Medicare plan finder, SNP care management, and statin therapy for cardiovascular disease. Most of these phase out between star years 28 and 29. Let's go to number 3. A new measure was added. CMS is also adding depression screening starting in star year 29, which continues the broader shift toward clinical and behavioral health integration and attacking mental health issues among the elderly. With that, we will take our first break, and when we come back, we will discuss the expected impacts of the star changes on the industry. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back to the Healthcare Labyrinth Podcast. My name is Marc Ryan, and we are talking about the final MA and Part D rule. We have been talking about star changes and now the impacts. So Part 2, weighting changes and the financial impact. Now let's talk about what really matters, how all of this changes the math for the industry. Because when you eliminate measures, you don't just simplify the program, you redistribute the weights of the measures. And that's exactly what CMS has done here. So a major shift in measure weighting. By 29, clinical measures, HEDIS and Part D drug, will be nearly 50% of total weight. Patient experience measures, CAHPS and Haas surveys, will be over 1/3 of total weight. Operational measures, they go to zero. Let me say that again. Operational performance no longer counts at all, and this is where many plans thrived. That's a massive philosophical shift. Plans that historically performed well in customer service, call centers, complaints, disenrollment, and more are losing a major advantage. What CMS says about all this is that about 25% of contracts will lose half a star, but that's only part of the story. Because many more plans will see partial declines, just not enough to drop a half star, but which makes it harder to gain stars in the future. Let's talk actuarial estimates that paint a worse picture. Firms like Milliman and Wakely Consulting dug deeper, and their findings are more concerning than what CMS says. Milliman says 30% of contracts could lose half a star, some could lose a full star, at least 42 contracts may fall below 4 stars. Wakely estimates a 0.25 star drop in the national average, about 1.4% revenue loss for MAPD plans. And remember, the 4-star threshold is critical because it determines 5% quality bonus payments. Who gets hit the hardest with this star changes? Well, SNP-heavy plans are the biggest losers. Smaller and mid-sized plans are also more exposed. Large national plans, well, some of them get hurt, but they are actually somewhat insulated. There's also a weird economic twist here. Because CMS kept the reward factor, some higher performing plans may actually see short-term gains, which will increase costs for the government, even as the system becomes harsher overall over time. With that, we will take our second break, and when we come back, we will discuss the remainder of the final rule. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve star scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back to the Healthcare Labyrinth Podcast. My name is Marc Ryan, and we are talking about the final MA and Part D rule. We've been talking about star changes, and now we will move on to other aspects of the rule. So let's get to Part 3, other key policies. Let's quickly run through what else made it into the final rule and what didn't. Let's first talk enrollment, benefit, and clinical oversight proposed changes. Provider network, special enrollment period. A special enrollment that would have allowed enrollees to switch plans when their provider leaves their MA network was not finalized. CMS said it will consider it for future rulemaking. Other existing SEP policies were codified in the final rule. Let's talk special supplemental benefits for the chronically ill. There were a number of changes here. First, a requirement that plans publicly post their eligibility criteria for SSBCI was finalized. Eligibility requirements were also clarified. There's also an SSBCI cannabis prohibition. Language was adopted to prohibit coverage of cannabis products that are illegal under federal or state law. As well, there was a supplemental benefit notification repeal. The final rule removes the requirements for plans to issue mid-year notices regarding unused supplemental benefits. There were a number of health equity provisions repealed beyond the repeal of the EHO for All reward. The final rule removes requirements for 1, MA utilization management committees to include a health equity expert, 2, the duty to conduct publicly posted annual health equity analyses, and 3, for quality improvement programs to include activities specifically designed to reduce health disparities. Let's move on to marketing and related changes. There was some waiting period relief for benefit counseling. The final rule eliminates the 48-hour waiting period between completing a scope of appointment and holding a personal marketing appointment. The rule also eliminates the mandatory 12-hour waiting period between an educational event and a subsequent marketing event at the same location. Other marketing reforms will bring flexibility as well. Let's move on to third-party marketing organization reform. Key changes impacting third-party marketing organizations and marketing were adopted, including updated language specifying the number of organizations and plans TPMOs represent, continuation of the TPMO disclaimer that is done verbally during sales calls, and reduction of the required retention period for recordings from 10 years to 6 years. Let's move on to the use of marketing superlatives. The final rule removed the explicit prohibition on superlatives such as best or most in marketing materials, but marketing content cannot be misleading, confusing, or materially inaccurate. A dollar value marketing was not finalized. A proposed ban on marketing the dollar value of supplemental benefits was not finalized. And on debit cards, CMS finalized guardrails related to the use of debit cards and supplemental benefits. Plans using debit cards to administer supplemental benefits must link cards to a real-time point-of-sale verification mechanism and limit card use to the specific plan year. Let's now move on to the Inflation Reduction Act Part D codification. CMS finalized the codification of Part D changes under the Inflation Reduction Act, including the elimination of the coverage gap, the reduction of the annual out-of-pocket threshold to $2,000, removal of cost sharing in the catastrophic phase, updates to true out-of-pocket cost calculations, clarification related to specialty tier drugs, reinsurance payments, and subsidy structures, and finally, implementing the manufacturer discount program that replaced the coverage gap discount program. Now, within the rule, CMS also, when it proposed the rule, had a number of requests for information. CMS sought public input on future modernizations in 3 areas. The agency received more than 42,000 comments on the proposed rule overall, but said little else in the final rule in terms of the comments. Here are the 3 areas they sought input on: risk adjustment and star rating programs. CMS sought broad input on changes to reform and modernizing the risk adjustment and quality bonus payment systems. The risk adjustment request stemmed from the overpayment controversy at large plans and views that the system may discriminate against smaller, newer, and regional plans. CMS may want to migrate to an encounter-based rate-setting system. Some within CMS and on Capitol Hill also want the STAR program to be budget neutral and not additive in terms of funding. MA has the only quality bonus that comes from added dollars. CMS also wants to reduce the 2-year time lag in ratings. The second area that CMS tried to get information on was oversight of chronic condition special needs plans, CSNPs, for duly eligible individuals. CSNPs have grown demonstrably over the past 2 years. Dual eligible special needs plans, or DSNPs, were meant to enroll dual eligibles, but more and more of these dual eligibles are going into the fast-growing CSNPs. CMS may want to require state Medicaid contracting for CSNP, as well as institutional special needs plans, ISNPs. And the last area CMS solicited information on was well-being. Coverage of well-being, including preventative care, mental health, and social connections, and nutrition policies. Additionally, CMS sought public input on approaches and opportunities to streamline regulations and reduce burdens on those participating in the Medicare program through a standalone RFI that they plan. In addition, in the proposed rules, CMS also asked for input on modernizing marketing oversight and agent broker regulations. With that, we will take our last break, and when we come back, we will conclude. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back to the Healthcare Labyrinth Podcast. My name is Marc Ryan, and we are talking about the final MA and Part D rule for 2027. I promised some closing thoughts, so here's Part 4, my closing thoughts. So what's the bottom line? This isn't a flashy rule. It's not filled with headline-grabbing policy changes, but it is quietly one of the most structurally important Medicare Advantage rules in years. That is largely due to the star changes. Trump 47 is very interested in overhauling stars, and we should expect even more movement in the future. The changes just announced fundamentally change how quality is measured, redistribute financial incentives, and increase performance pressure across the board. We should expect more star volatility, more revenue compression, and more strategic repositioning by plans, especially as we move closer to full implementation in star years 2028 and 2029. So if you're a plan, this is the time to rethink clinical strategy, member experience, and data capabilities, because the margin for error is getting smaller. In another revenue area, risk adjustment, we are also seeing major changes, which will mean even tighter revenue overall for MA plans in the future. Thanks for listening to the Healthcare Labyrinth Podcast. If you enjoyed today's episode, be sure to subscribe and share it with colleagues interested in healthcare policy. Until next time, stay curious, stay skeptical, and keep navigating the healthcare labyrinth with me. We will find our way out together. Again, I am Marc Ryan. This is the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Marc and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.